Thank you very much. Sorry, I'm just getting settled after a bit of a rushed afternoon. Just give me 1 minute. I'm just going to line.
Okay, ma'am. Smriti ma'am is busy. If any of you have any feedbacks to share with us, please you can unmute and speak yourself.
Senior, sorry to interfere. Sripriya this side. Hi everyone. Before we move on to like the session, I would like to introduce Ms. Smriti Rana, who is presently heading our the strategic partnerships and community engagement department at Palliative India. She has a master's of science in integrative and holistic psychological counseling with 18 years of experience in palliative care. And she is that one person whom I personally would say that whenever you see her, the positive vibe surrounds you. No matter how hectic she is, how tightly packed her schedules are, whenever you ring her up, she makes sure that your call is listened to in such a way that you feel that your work is almost done for whatever matter you call you. It's really our honor to have you with us, Smriti ma'am, today. And we do hope that we will be having a wonderful and interactive session as usual, because all your sessions have been like that only. Senior, over to you.
Sripriya,
Thank you, Sripriya ma'am. And Smriti ma'am, welcome once again.
Thank you. And thanks, Sripriya, for really setting the bar a little higher than I would have been comfortable with. But thank you very much. And good afternoon, everybody. Thank you for joining us for this session. And I just want to apologize for this little delay from my side. I think all of us have now sort of settled into this pandemic world, and these kind of critical emergencies keep arising from time to time. I hope in the meanwhile that all of you are safe and keeping well. As always, in the other sessions, I'm going to ask you as far as possible to keep your cameras on, because I find it quite difficult to talk to a room full of screens. Today, the topic we're going to cover is equity. And I just want to understand, before we go into the session, what do you all understand of equity? Yeah, feel free to type it in the chat box. I have access to it. And if you want, please unmute. If you want to tell me a little anecdote about what equity, how equity was described to you the first time, or the first time you experienced what the importance of equity is, I'd be really interested to hear from you about that as well. So I know we usually take a few minutes to warm up before people start getting chatty. But like I said, feel free to unmute and share your thoughts. No thoughts on equity? Is it the same as equality? Are equity and equality the same? You can also use your reactions. Oh, they've got a whole new bunch of emojis in the reaction section now. I didn't know that. Okay. Equal rights up to their needs, equal share in decision making. Yes. Okay. Any other thoughts? Okay, let's we'll start unpacking the idea of equity as we go along. But I also want to highlight here that you might think, what does this, very sort of as today's session is more looking at it from a public health lens. But I want to reinstate the fact that palliative care, we're trying to integrate it into mainstream healthcare, and mainstream healthcare is part and parcel of a larger ecosystem of public health. And if the public health system is not working correctly, then healthcare is not working correctly, and neither is palliative care. So we're all interconnected, and that's why when we study things like pain management, end of life care, shared decision making, advanced care planning, all of those things that are so palliative care centric, we need to remember that none of this can even exist if we don't understand the public health system and what it allows us. What is the maneuvering room with the public health system? How resources are distributed across different sectors, across different communities and regions. And we already know that the access to palliative care is abysmally low, in not just in India, but in the most part of the global south. And when I say global south, that's the new fashionable way of saying developing world. So we know that even when it comes to opioids and pain medication, controlled medicine, a lion's share of the portion is with more advanced countries, with the global north, so to speak. And they also have access to things like national health insurance schemes and so on and so forth. Whereas in India, we know that 2.5% or less than 2.5% of the GDP is even geared towards healthcare. So finally, we're just paying for it out of our pockets. And as I've said before, we know that now 55 million Indians on an average are pushed below the poverty line annually because of healthcare expenses. And out of those 55 million people, 38 million people are pushed below the poverty line because of just the cost of medicine. Does that sound like an equitable system? So all of these things really sort of feed into one another, and that's why it's really important for us, no matter which part of healthcare we plug into, whether it's palliative care, whether it's primary care, whether it's tertiary care, whatever it is, it's important for us to understand these concepts. And I know some of you already might have a good background in that. So if for some of you this is all really old hat stuff, then I apologize in advance. But for those of you who do have experience in this area, I will invite you to please share your knowledge with us, because these sessions are mutual learning platforms. Okay, so I'm just going to share my screen and we can get started. I'm going to also approach this. So there are two layers. One is the aspect of equity, but the other aspect is we're looking specifically in how important assessment is in fostering equitable care. Now, if you don't get your assessment correct, then the measures and interventions that you apply can be a hit and miss. So 1 second, sorry. Yeah. So the fundamental practice in anything is to make sure that your assessment is thorough, your assessment is objective, and then the decisions that follow that assessment then can serve what the needs of the people are. Because if you go into a particular setting and you feel like, okay, this seems very similar to other settings I've been in before, so I'm just going to assume I know what they need, but then that can be a big miss on our part. So just to sort of reiterate that we're coming at this from the lens of assessment and how important assessment is in ensuring equitable health. So yeah, okay. Senior, is the screen clear?
Yes, ma'am, it is clear.
Okay, fine. So I have to mention that this particular slide deck, I'm sitting in for a colleague, Dr. Deepak Varghese, who actually put this slide deck together. He did his community medicine from CMC Vellore, and he worked with Palliative India for about 2 years. And really, I've learned so much from him, because it's through him that I understood, these aspects better. And so I'm using his slide deck, and if I get stuck on certain questions, then I'll be sure to take them from you and get him to answer them and let you know what they are. Okay, so what is the objective of the session? To understand the concepts of equitable distribution in health. And by health, automatically it impacts palliative care services as well. And understand the basics of clinico-social assessment, keeping equitable distribution in mind. So you have to go in from that lens, because that lens will then determine what questions you want to ask. And it's a clinico-social, not just a psychosocial, but a clinico-social assessment that we're going to be doing. Okay, now my question to you when we started was, are they the same thing? Okay, and we've already sort of put that question to the floor. And please feel free to keep using the chat box as even as the session progresses. From time to time, I'll pause and we will go back to what is in the chat box. Okay, now we have a very diverse country, as we all know. Most of us probably reside here somewhere in the middle. And the diversity is now so stark and so obvious that for most of it is invisible to a lot of people. We drive by slums, we drive by, high-rise buildings right next to slums, all of that, and it's so part and parcel of our everyday commute, of our landscape, that we don't really pause and think about what it might mean to actually be in any of those settings. Although I'm sure that if you are here in this classroom, that means you do care a lot. So I wouldn't extend that to you guys. Okay, let's take a case study. Okay, now, would anyone like to volunteer to read this out for me? Anyone from the audience wants to unmute and just, take us through Priya's case? Senior, if nobody puts their hand up in the next 5-10 seconds, then would you do it? Or would you?
Ma'am, I can read it out.
Okay, great. Go for
Priya
it.
is a 20-year-old woman. She's pregnant.
Sorry, Senior. I think Avantika unmuted. Sorry. There you go. Thanks,
Okay,
Avantika.
Avantika.
Priya is a 20-year-old woman. Am I audible?
Yes, clear.
She's pregnant with her first child. Her husband is a manual daily wage worker. He lives 30 kilometers away. She needs to visit the hospital for her delivery. The local bus or a cycle is her only mode of transport. A neighbor owns a van that can be used for emergency. Her husband is anxious. Every time he takes her to visit the doctor, he loses a day wages, apart from paying the doctor's fees.
Thank you, Avantika. Okay,
Welcome, ma'am.
what are some of the first thoughts that come to all of you? Okay, what are some of the challenges faced by Priya in assessing care? Okay, let's just say what are some of the challenges, right? She's pregnant with her first child. We know that she lives far away. She's in a village. Her husband lives 30 kilometers away. Transport is in. So what are some of the thoughts that are emerging for you? Some of you are parents. You've probably been through the whole experience of having a child. And what would be some of the concerns here? And what are some of the opportunities also? Apart from the obvious, apart from what is written on the screen. Okay, I see the chat lighting up. Emotional turmoil during pregnancy, of course, a lot of stress, huh? Husband not being cooperative during this time with her, since he's quite worried about his wages. Yeah, but he also needs his wages to pay for their living expenses. Lack of support. Okay. Lack of support in what way, Avantika?
Lack of support, ma'am. Like, husband is so far. He's busy with his work, and they don't have proper means to go. And there's no like support from the family. Like, if husband is busy, so somebody from the family is also not there to help her. So that is also a lack of support she's having.
Yeah. Thank you. In case of emergency, it's very difficult for him to bring her to the hospital as he lives far away and the van is the only vehicle. Yeah. And if you think about the transport, this is actually one of the social determinants in seeking healthcare for women, where a woman taking public transport alone for a distance of 30 kilometers is also not safe for the woman, or it's not perceived to be safe, right? Safety is an issue. So, I mean, this is a story that plays out across India. If a woman needs to get assessed, even in a clinic for, like, say, getting screened for something or whatever, she has to travel with somebody, especially if she's young or if she's in a fragile state. Financial burden is huge for the family. Yes, that's right. Okay, so we've kind of safety is, yeah. So we've unpacked this situation with Priya. Now let's look at Reena. Would someone else like to just take us through Reena's case? Would anyone like to unmute and just read this out for us? Tabinda?
I like.
Lovely. Go ahead.
So, ma'am, am I audible, ma'am?
Very clear, Tapan.
Reena is a 29-year-old woman. She works as an advocate in a prestigious law firm. She is pregnant with her first child. Her husband is the owner of a local business. His business is also doing quite well. They live a relatively comfortable life. She has a stable job paying her a fixed salary. She drives an SUV. She gets 90 days of paid maternity leave. Her company also offers her medical insurance.
Thank you, Tabinda. So two women about the same age, and this is the difference. So what would be the difference in this case?
Ma'am, there's a lot of security in her case. Whereas in the other one, she was very insecure even about the transport, about her company, somebody accompanying her in times of emergency, and no hopes of help.
Okay, thank you.
That's
Thank you so much.
no financial burden.
Well, yeah, no financial burden, that seems obvious to us. She's in a safe and comfortable situation. The socioeconomic background is different. Thank you, Gautami, for pointing out that Reena would still need the emotional support of her husband and her family. So that's something we all need, irrespective of our backgrounds. Yeah, now, similar stuff, if you were to imagine, if it's not a pregnancy, but an illness, right? Suppose that these two women had different kinds of cancer and needed treatment on a regular basis. Okay. So whether it's maternity issues, whether it's a serious health related issue, whether it's, so these are all different things that play out. And so we're using the lens of maternal and child health here, but I also want you to process this in terms of illness. If this was an illness, what would have happened? Okay, now what would you do? And this is a question that was posed to doctors, so let's forget that. Offer the C-section at the same cost to, Mary and Sylvia is supposed to be Priya and Reena, by the way, at the same service. Offer different payment slabs to both, with Priya paying a subsidized amount, or would it be something else? So what is the ideal system here? Both of them need a C-section, and the cost being the same. Now, in a community health setting, this is a question that is perhaps posed to the doctors, but let's look at it in a different way. Suppose this was a palliative care setting, and you know that what this person needs is a particular procedure or an intervention. And would you offer the same thing to both of them? Would you cross-subsidize? Is there any other way of doing this? Have you come across any other models that might work? So this is just something for you to think about. We don't have to spend too much time on this. Okay, so the real difference between equality and equity is that equality has the quality of sameness. Everybody gets the same thing. So in this case, Priya and Reena would both get the C-section. So we're giving them both the same thing, same quality of service, right? But equity is fairness, access to the same opportunities. So I'd like to, if I give Reena and Priya the same C-section at the same price, I'm giving them the same service, but what am I doing to Priya's family? What would I do to Reena's to Priya's family, the one who lives in the village? Say the C-section costs X amount of rupees, right? So what would happen to Priya if she had to pay for that amount? She'd get the C-section, but what would be the outcome? What would be the aftermath? Financial burden. Yeah. Huge economic debt. Yeah. It's unfair. Yeah. All right. So let's look at it from the lens of palliative care. Two cancer patients they go to the same doctor, or they go to two different doctors. They put on the same regimen because it's the same kind of breast cancer, but the regimen costs a devastating amount for one person. The other person, it's fine, they can afford it, right? But access, it's not saying that based on your socioeconomic background you should get less quality or cheaper drugs or less effective medication or interventions. What we really need to do is make it accessible to them. And how do we make it accessible? The entire system needs to work together to make it accessible, right? So there could be a system of cross subsidizing, there could be various other things. So I'm not here to comment on that in particular, what those interventions need to be, but this is just to make you think about what is accessible and available to one person may not be accessible, maybe available to the other person, but not accessible to them. So please, I can't say this enough, something can be available, but not accessible. And the gap there is the affordability. Those are the 3 A's. So something can be available, but not accessible. And what is the barrier? It's affordability. And we see that time and time and time again playing out in palliative care, in oncology, in any kind of healthcare system, right? Okay. So again, this is another graphic description. Inequality is unequal access to opportunities. The system itself is skewed. Equality is both are given the same tools, but since the system is skewed, the 2 people can't get access to the same thing. Equity is when one person is given what they actually need in a fair way, identify what the need is, and then give them what they need in order to be able to access what is required by them. And justice is, of course, the most idealistic of this whole thing, is where we fix the system to offer equal access to tools to everybody. So these are the 4 components that, or the 4 sort of ideologies that we need to think about. Okay. Right now, I would say, as a system, we're not here. We're still somewhere between these 2. Okay. All right. I'm just gonna. Some of you might have watched this video, but this did the rounds. It went viral some time back. It's again from an American context. And let me see if I can share this without losing quality. And Senior, just let me know if the audio is also coming through. You might hear my dogs barking in the background. That's not part of this video, but all right. So Senior, just give me a thumbs up when the sound comes on, okay?
Okay, ma'am.
Hey, line up. Line up. Everybody line up. We're about to race. Everybody line up. Shoulder to shoulder. Take off your backpacks. Basketball, line up. We're about to race. Hey, we are racing for a $100 bill. The winner of this race will take this. A $100 bill. Before I say go, I'm going to make a couple statements. If those statements apply to you, I want you to take 2 steps forward. If those statements don't apply to you, I want you to stay right where you're at. Take 2 steps forward if both of your parents are still married. Take 2 steps forward if you grew up with a father figure in the home. Take 2 steps forward if you had access to a private education. Take 2 steps forward if you had access to a free tutor growing up. Take 2 steps forward if you've never had to worry about your cell phone being shut off. Take 2 steps forward if you've never had to help mom or dad with the bills. Take 2 steps forward if it wasn't because of your athletic ability, you don't have to pay for college. Take 2 steps forward if you never wondered where your next meal was going to come from. I want you guys up here in the front just to turn around and look. Every statement I've made has nothing to do with anything any of you have done. Has nothing to do with decisions you've made. Everything I have said has nothing to do with what you've done. We all know these people up here have a better opportunity to win this $100. Does that mean these people back here can't race? No. We would be foolish to not realize we've been given more opportunity. We don't want to recognize that we've been given a head start. But the reality is we have. Now, there's no excuse. You still got to run your race. But whoever wins this $100, I think it'd be extremely foolish of you not to utilize that and learn more about.
So that was a very, like I said, it was a very American university exercise. But I think it highlights some important points, which is applicable across cultures and across demographics. And why I wanted to share that video with you is because, and when we talk about mental health as we go forward, in this program, we will be talking about how some things are a result of not, like he said, anything we have done or caused, but just where we come from and what the opportunities our parents have had, what sort of cultures we live in, who is given what opportunity based on gender, based on color, based on sexual orientation, and so many different things. And when you come to a space where you are critically sick, that's when you're at your weakest, right? So when do you need palliative care? You need palliative care. Typically, the understanding is when nothing else can be done for you. But so that's probably one of the most vulnerable times in your lives. And imagine that it's not just the sickness that is making you vulnerable, it's all of these other social factors that have happened, that existed even before you got sick, right? So if you are completely dependent on one person's earnings to keep your family afloat, and that person gets sick, it's a whole other ballgame, right? If you have a support system, it's a whole other ballgame. If you have access to subsidies, it changes things. And all of these things change from region to region to region in India. You can say that there's a PHC within 1 kilometer of this person's house, but it could be in a very, very mountainous terrain, and this person can't walk. So that's also an equity issue, right? So universal health coverage talks about health for all, health with all, meeting people where they are, giving people what they need, when they need it, where they are. It's very lofty, it's very utopian. The ground reality, especially in a country like ours, is very, very difficult. So whenever we talk about the interventions that we use, whether it's in palliative care or healthcare, these are some of the social determinants we need to talk about. I wish we could make a video like that for India. It would be a full-length feature. Anyway, let's carry on with the rest of the session. And I'm happy to get your reflections on that video in the chat box. If anything about that video struck you as important or struck you for any reason, please go ahead and put your comments in there. Okay. Now, how much should people pay for services, right? Patient-to-patient subsidies. You have different models, and so in some cases, like I said, it is cross-subsidized by other patients. So some people are charged, and some of those proceeds are put towards pro bono. So you have like a quota of people that will get free services based on what the other people pay. Everybody gets, or it's a situation where everybody gets to pay regular rates. And in some cases, you have concessional rates. So if someone is able to show a below poverty line card, they're able to get certain other services. Department to department subsidies. A profitable department subsidizing a less profitable one, that makes sense. There are so many profitable departments in healthcare, right? And how about if some of that goes towards a less profitable department, like say palliative care? Because let's face it, palliative care is not a very profitable department in that sense. Do patients perceive free as cheap? And this is an important question. This is a very important question for all of you. Now, I want to stop sharing my screen here because I want to really discuss this question. One of the pervasive myths around palliative care, because a large part of palliative care in the country is provided by civil society bodies and NGOs like us, and we typically give out free services. Do you think that is a barrier in some way? Does it make people feel that this is a service that is not worth much? Because let's remember, in India also, or anywhere for that matter, if somebody I love is sick, I want to give them the best care. And the best care must come at a cost, right? Does the best care ever come free? And what will the neighbors say? So just Think about this. Free services, sometimes will they act as a barrier to accessing that service? Stigma attached to free service, perhaps? I'm just going to let this question sit with you for a bit. I'd love for some of you to give me more responses. Hema, would you like to say something?
Yes, ma'am. So I work for the trust called Mother Trust, and we work for cancer patients at Tata Memorial Hospital. So this point that you're saying, we see it very often there because we have two classes there, the general and the private. So the general is generally people from the really economically background, bad background kind of a thing, low background kind of a thing. So the first question when they enter and they ask us is, if I'm in general, will my treatment not be as good as the one in the private? Their main concern, in fact, most of them, a lot of them, in fact, go to the private thinking that they are not going to get the same care if they are in the general.
Thank you, Hema. I can see a lot of resonance in the chat box from other people also. Prestige issue, yes, absolutely, yeah. How much did you spend on your mother's treatment? Oh, I paid, 3 lakhs for this and 1 lakh for that. And this doctor, the best cardiologist, came and his fee is like, how much he charges per hour. Haan, theek hai, bahut acha kiya. I took her to this free palliative care service. And people who don't understand it are going to turn around and have many things to say about it, right? Many people think that anything costly is good, so anything that is cheap for free must not be worth it. Yeah. Nupur, I see you've unmuted. Would you like to say something?
At times it has happened that yes, is that many patients' family end up exhausting all their financial needs, and then they come to take our services because of free. But at the same time, they are in life, they don't get the best possible care because they are under the impression that if they spend more money, they'll get better doctor, better nurse, and better care.
Yeah.
So they still fall to some services where they can pay, but at the same time, they are so stuck with spending, they're really so much that they don't have any other money to spend on these services.
Absolutely. Thank you. And you can see why this is contributing to the overall impoverishment of people because of healthcare expenses. So much of it is perception, right? And recently I was talking to somebody who was so worried because, the father was visiting and they were worried that he had COVID. And so when they went to get him checked, he was negative, but then because it was a big hospital, they said, while you're here, you're 70 years old, let's do some other tests. They found something. Then they said, no, you need a stent. And they were trying really hard to figure this out. Finally, they went to a government hospital where this old, this experienced physician was there. And he said, absolutely not, you don't need it. I mean, it's 300 rupees is what you need to actually fix whatever the problem is right now. Now, but had he not, but how many people would even go to that hospital, right? No, so this is, again, one thing we talk about is we are at a very precarious point where the healthcare service in some cases operates as a healthcare industry and not a service. And we call it the healthcare industry, right? So what does industry mean? But I'm not here to bash the healthcare system. I'm part of the healthcare system. So of course, I'm not here to bash it. But these are just things for us to remember that sometimes a free service or a cheap service or economically viable service is considered not as good. And that's one of the biggest barriers. And sometimes when you're having a conversation with somebody trying to encourage them to take palliative care, you need to explain this part as well. So that's just something for us to bear in mind as we go along. And that's one of the reasons I wanted to sort of pause over here and just go over this question. And also the problem here in India is that a lot of people associate palliative care as charitable service for the underprivileged, and they would not want to be part of that, right? Okay. Now, best care is where the caregiver displays a sense of togetherness and impartiality with the patient. Rates are different. Yes, absolutely. And most people I've interacted with at the end of the day have lots of good things to say for people who offer those free services. Okay, now case taking. Now this is where we're sinking our teeth into the heart of this particular session. Case taking is not just simply going and having a conversation with somebody and saying, what's your problem and how can I help you? It's a very systematic approach to getting the issues we need to identify problems using the patient as the index case. Okay, so it's a systematic approach to getting the issues we need to identify and the problems we need to identify using the patient as the index case. The sentence construction is a little bit not great. So, all right, but you get the gist of it. Now, we're going to go into what that case taking should look like. And I just want you to know that these are just suggested questions. You don't have to ask all of these questions. Some of you might find some questions actually relevant to your setting. Some people don't need to actually go into those questions, but here's just the full gamut so that you can choose, take your pick. It's also very important to remember that really, if you want to do a full assessment, you have to see what the home setting is. And that's where the home care service is actually quite unmatched. When somebody comes to the outpatient unit or comes to a hospital setting, you see the person and maybe the family, and you get a sense of their dynamics. They tell you what their situation is like. But it's only when you go and visit them in their house do you really understand what some of their challenges are, which they may not even see as a challenge, but in providing care, they can pose as challenge. Certain questions are observations that need to be seen and not necessarily asked. So some of the questions that I'm going to take you through, those are just guiding questions for you. So you can make a note, these observational points not to be asked outright. And whatever it is, we always, whether it's in mental health or in palliative care, we encourage non-judgment and an unbiased perspective whenever we encounter anybody. Okay, so let's start. So the overview, I'm going to take you through 10 areas and we're going to talk about information about the area that the person lives in, general information about the patient, some of the social schemes that they might be having access to, details about the family, the socio-economic status, health system issues assessment, assessing the environment, assessing nutrition, clinical findings, ideas, concerns, and expectations. So now between these 10, you're looking at external stuff, which is on a macro level. You're looking at meso stuff, which is at the family level. And you're looking at the micro stuff, which is at the individual level. So we're looking at, a systemic thing as well as and working our way concentrically into different circles of their existence, really. Okay, so let's talk about information about the area. What is the name of the area? So obvious. But why do we need to know that? Because if you are working with the healthcare team, is that area prone to any other endemic diseases, or are there other health issues that from time to time spring up in this area particularly? Is it next to a stagnant water body? Do they have vector-borne diseases? Do people end up in this area getting a lot of, say, cholera in certain seasons? So are there other issues with that area? And I'm sure those of you who, if you just put your mind to it for 5-6 minutes, you'll realize that people living in certain areas in your city, you hear about this, right? Or that area is a little bit infested. That area is a little bit, it's closer to the industry, to the factory. So there's more smoke in that area, whatever it is. Are there any outbreaks in the area? So those are some of the reasons why we want to know what area they're in. What is the name of the nearby primary health center? This can be useful information later on when you're coordinating care, especially since the PHC may be the facilitator for various schemes. So this is not information you may need immediately, but it's good to have in the background. And also please remember, sometimes the PHC might have a name, but it's closer to another area, right? The PHC of that village or the person in that village may actually be close to the neighboring PHC rather than the one in their immediate vicinity because of them being on the outer radius. Okay. What is the distance from the main road or nearest public transport facility? And this is important because we need to assess whether how difficult or easy is it to shift the patient, especially if the patient is a bed-bound patient, is a wheelchair user, is an elderly patient, things like that. And this is why we need to understand what is the distance from the main road or the nearest transport facility. Okay. I'll just illustrate this with a point, and let me see if I can pull up that that picture while I'm talking to you. So we actually, we met with this patient. One second, I think I have this picture right here. Just give me a second. Huh. So here it is. Oops, I'm sharing the same one. Sorry, just give me a second. Of course, technology will fail you when you need it. Can you see this? Senior?
Yes, ma'am, we can see that.
Now, this young man over here, he was not even 23 years old, okay? And when we found him in his home, he had been in a car accident maybe like 3 years ago. And in those 3 years, so he came back from the hospital, he was discharged, he was told he needs physiotherapy and then he will regain functionality, etc., etc., etc. That lady at the back is his mother, okay? This is a neighbor. This guy, as you can see, he's not small built. He's quite heavy set. Their house is this 1.5 room house, literally. If you step outside the house, there's a step that is so high. And then you have to walk upwards to a hill. It's a untarred road. It's a path. And you have to, climb around rocks, etc. Then climb down a hill for another 500 meters or so. And then you have road access to where an auto rickshaw can come. So what happened with this guy was that he couldn't go for physio because his only caregiver was this lady. And this lady worked in the plantations, in the farm, like in the plantations. And so she had to keep going to earn a living. So this guy would just sit at home. He couldn't even get off the step, forget all of these other things. And if he had to go to the physio, 4 men from the village needed to come, put him either on a chair or on one of those, rope khatiyas, hoist him up, carry him all this way, and then get him to an auto and go. That meant that they needed to take time off work to do this. So end result, no physio for 3 years. He got more and more immobile and debilitated. Finally, after 3 years, we found him. We organized some care. Our home care team visits him. What we did is set up a simple thing in his house where he used it to walk himself up and down. And he's now far more mobile, and now it's easier for him to actually get better care. Okay. So it's what I'm trying to say is it's a very common scenario in our country. And so, this kind of stuff happens all the time. And this is where home care services, and this is why it's important to understand the geographical terrain of the area, because it's very easy to sit in a clinic and say, come for physio once a week for the next 3 months. Yeah. Okay. So type of road, is it a mud, cement, tar? It indicates difficulty of access. In some cases, predominant caste in the area or predominant occupation in the area, especially important in rural settings, caste and occupation are often linked to one another. This is not a comfortable conversation for a lot of people, but why am I saying that in some cases, this is an important question to ask, if we're being really honest? Is caste a determinant of access to healthcare in some parts of the country? Or are we going to say yes? Thank you, Vani. During the COVID second surge, I was in UP and I met somebody who was very sick. He had COVID symptoms. This is in the big second surge. And so, young 45-year-old man. And he used to occasionally come and help out in our house and stuff. And I said, you better get to a hospital. And he looked at me, he said, Didi, kya baat kar rahe, hospital mein mujhe dakhil nahi karenge, which means they won't admit me in the hospital because of the caste. Yeah. And if it does, and it's something that Yes, are treated badly and don't get access. Exactly. So it is important for us, if we're really going to go out and offer this kind of care, these are uncomfortable questions, but we have to ask them. And or if not ask them, at least do our research about that. Okay. You also have, in a lot of villages, and doesn't even have to be in a village. It could be even in a particular part of the city, where you have the main settlement and then you have a colony. And usually the colony belongs to, the classes that are considered to be of a lower socioeconomic bracket, or of the value placed on the caste itself. And then you might have the well here for water, but these guys can't come, right? So access matters there. Okay, now, so we've talked about general stuff. Now we come to more, specific stuff. What is the name of the respondent? What is the age of the respondent? Obviously, that stuff where you're going to get. What kind of family do they live in? It's nuclear, joint, 3-generational, and all of these things have an impact on the decision-making dynamics as well. And if you have a nuclear family, it's a different sort of decision-making dynamic. If you're a joint family, there are adjacent relatives who are part of that. If you're 3-generational, obviously, then you know who's the patriarch, matriarch, and then you find that the youngest daughter-in-law is the bottom feeder, and then you have, you have various such structures that are completely understood, and who gets to go where, who gets to access. And also it tells us how healthcare resources are allocated within the family. Who gets access to the money in the household towards their healthcare expenditure. Very important social determinant for women. Religion, of course, caste I've talked about. Is the person a ration card holder? And if yes, which color? How many of you here are familiar with ration card colors and what they mean? Is everybody here familiar with that? It was a very relatively new, yeah. Okay. I'm ashamed to admit that I understood it very late. That in and of itself tells me about my privilege. That I never needed to know the color of my ration card, right? So, okay, we'll talk about that in a second. Are they using the public distribution system? There's a spelling error there. Public distribution system is basically for, resources being shared. Like, okay, so this is to ensure that food security to a certain extent is maintained and so on. Do they have a government medical insurance card, and what kind is it? Like in Tamil Nadu, you have different kinds. In various other states, you have different kinds. Okay, now I just want to quickly take you through what the ration card color coding system looks like. You can actually Google it and find out also. White is a non-priority ration card. So there are differences in the price at which it is available. Blue is subsidy, pink is priority, that is BPL. Yellow is probably the highest priority, where you get 28 kgs of rice and 7 kgs of wheat for free. So it's all dependent on the socioeconomic bracket of the person. So the card color actually tells you how much you're able to access from the public. And different states have different colors and different schemes. So please check your respective states. Okay, and this is dated information, so this information might also vary, but this is important for all of us to also understand. Okay, now that you've got all of that, you could also create a matrix of this kind of a thing, where name, relationship to the head of the family, age, sex, marital status, education, occupation, income per month, health status. Are they receiving any pensions? Do they have any alcohol or tobacco habits? Why is the alcohol, tobacco, or any substance use habit important to know? Because it's a resource sink. Somebody who is addicted is likely to take that money which is allocated for something else and actually blow it up on their choice of substance that they're addicted to. It is a resource sink for a lot of families. That's not to say that we judge the person with the addiction. We're going to be doing a whole section on addiction. It's a subject that's particularly close to my heart, but it's important from the socioeconomic perspective, because that can be a huge place where people lose their finances. And okay, so I'm not going to go into the details here. This is getting a little too technical, but what is the family's total income? if you take everybody's, and then if you divide it by the number of members in the house, it tells us the per capita income of the family, right? And depending on what your result is, you have these different categories, and that can tell you what is the per capita income of the family and whether they're upper, middle, lower class, whatever. And again, now this is, if you really, this is for social workers also, if you really want to sort of get into it, if cost is where you're coming from, expense on food, if you take that per capita income and see what is the expense on food, what is the expense on rent, electricity, medical needs, other technology, mobile, telephone, etc. How much do they manage to save? Do they have any debts? Do they have any other expenses? And if you make a chart of this, you will also realize how much money then they have left over for healthcare expenditure. Yeah. And then in the family, you see who is prioritized. And you say, okay, fine, if the head of the family is prioritized, it's likely that majority of that health expenditure money will be saved for that person, or the boy child, or whoever, the favorite in the family. So various things like that. Now, do they have access? Is the PHC available? Is it accessible based on all these factors? Is it affordable to them? Is the quality of care in that place good? And do these people actually go there often? Similarly, for a government medical college, is it nearby? Is it available where they live? Yes. Is it accessible to them? Are they able to afford even that price? What is the quality utilization? And you can do this across stuff. And if particularly in a palliative care setting, you can also bring in a palliative care service. Do they have a palliative care service in the area? And do they check all these different boxes? Okay. Presence, especially in the case of people, so this is again a public health, more of a community medicine perspective. Is there an accident prone area close to their house for any reason? Like, is it a place that's given to landslides? Is it a place where the roads are bad and therefore, people have traffic accidents or whatever? Stray animals that might be a deterrent for them to walk. Open drains that could be vector breeding sites also, and any other significant observations. Now, these are all observations. As you enter somebody's home, these are things that you might want to tick off in your head. And also to check whether there's a presence or absence of ramps, railings, if there is a disabled person. And really, can a bedbound person be shifted in and out of that house is something to add on if you are a palliative care person in that sense. Some places, what happens is that the door to the house itself is so narrow. So even if you have to carry the bedbound person out, the bed won't fit. The width of the bed is broader than the width of the house door. Right? So those kind of things as well. Right? Okay. All right. Now, not all of us are artists, and I would say the person who drew this is also not the greatest artist, but we get the message, right? So don't let this deter you. Just like you do a genogram, I did not draw that, by the way. I just want to say that for the record. But mine would probably be worse. You can see this is Western because there's, okay, fine, maybe this is from the hills because there's a fireplace and stuff. So you can very quickly, just like how you do a genogram, when you're drawing a genogram for your family and all of that, you can also do a quick house plan. Now, why do you want a house plan? Because especially if you're working with a person who is bedbound or has a disability, this becomes important. What are the rooms that they have access to? Do they have access to a window, right? And we might tell the patient, every once in a while, bring the person to the living room. We might live in a joint family where there are 5 people there to look after the grandmother, but the grandmother spends all her time here. The family spends all their time here. So it's only naam ke vaste that the family lives together, right? The grandmother is entirely alone. Nobody's talking to her. Okay. Now, type of house, is it owned, rented, leased out, which means do they have any debts to pay? Do they have to have a monthly thing? Is the landlord being mean to them? Things like that. Is it a kacha pakka house? This is a problem that we see a lot in Trivandrum, where one of the biggest needs that people have is to get their roof fixed before the monsoon because of the rain. and our social workers will vouch for that. So the home care team goes there with the medical kit and everything. What do you need? I really need my roof fixed. That's also palliative care. Okay. And are they at risk for, the wall crumbling on them? So is the floor even or uneven? That will affect mobility. Infestation of rodents present or absent. Well, that's just something you can observe. Is the roof thatched, tiled, asbestos sheet, others, leakage in the roof, like I was just talking about. And you don't have to go into all this detail, guys, but look out for dampness, because people with respiratory issues and stuff, if they're living in a house that is damp, it's going to exacerbate the issue no matter how many medicines you give them. Okay. Now, okay, number of living rooms per capita. Okay, this we don't have to go into too much. I'm going to skip these. We'll be sharing these slides with you so you can actually, unpack this a little bit more. But in the interest of time, I'm just going to move past this. Crowding. Now, if a person, this is also kind of important when, especially from the dignity issue, right? If somebody who is incontinent as a patient, or needs a bedpan, or needs, so on one hand, yes, you have the family to support and help and stuff like that, but also privacy is a problem, right? Women with cervical cancer, advanced cervical cancer, it's one of the most distressing kind of cancers, because first of all, it's caught very late. Because it affects the genital tract. It also leads to a lot of fistulas and stuff. So there's leakage of not just fluids and blood, but also of like fecal matter and things. And this is in a place, and in a lot of parts of India, we don't even have proper access to menstrual hygiene products. So in some cases, all of this, which is very malodorous discharges and things like that, if it's an overcrowded house, she might just be put outside. That happens. 40% of women with cervical cancer are abandoned by their partners. So this kind of stuff is also important to know. Yeah. Okay. Because if they're sharing space with so many people, it will impact the level of care. We mustn't assume that just because lots of families there, that means it's a supportive family. Okay. So we can skip this part. Assessing ventilation. Is there ventilation in the house? A number of doors, kept open, etc. This becomes particularly important in certain peculiar cases where when there's breathlessness and stuff like that, having a fan towards them, having cross ventilation is really important. So these are like non-pharmacological techniques to manage somebody who, if in case their breathing gets distressed, sometimes the not being able to breathe makes it even worse. And I'm not just talking about COVID, I'm talking about advanced cancers and things like that also. And we're having a window not just serves the purpose of light, but sometimes if somebody is bedbound and if they can just be moved to the window, they feel so much better. Yeah, so those kind of things also really makes a big difference. And I've seen that happen not just in very, socioeconomically challenged families, but also in extremely affluent families when they have a 80-year-old grandfather with dementia who's bedbound. And the simple act of moving the bed close to the window has cheered this man up. Okay. All right. Is there enough light in the room for them to read if they like reading? And at least in 2/3 portion of the house, or are they in a dark place? So, somebody who's unable to move, doesn't have access to even, I find that a lot of homes, they're just plonked in front of the television and they're basically assaulted by whatever's on TV. And they have no choice but to watch whatever's on TV because they can't change it. Right. Or so assessing lighting is important, assessing the kitchen, where is the kitchen in the house, how convenient is it, and how is food stored, do they have storage space, is there a smoke outlet, especially for people with certain kind of illnesses? This makes a difference. Is there a separate washing area? How is silage disposed, etc., etc.? All of these can make an impact. So I don't want to I know we're getting into very, very nitty-gritty details. I don't want to get into it much further. This has been seen as a major problem for a lot of the families we work with, because they don't have access to water in their own homes. And very often the primary caregiver, who's already under so much stress, has to walk a couple of kilometers to get water and come back. And in many, many cases, one of the priority areas for us as Palliative India with our patients has been to try and get a bore well installed nearby, or to create a water source. Yeah. Okay, so all of this is just adding to that. And in terms of health and hygiene, do they actually have the privacy for bathing? Do they maintain it? Is it actually a space where it generates even more, like, fungus formation and so on? And toilets are of course very important, and that has a huge impact on their health. So you don't have to get into major details of it, but then just to know where it is it accessible to the person who needs to use it also? And how far is it? Where in a lot of cases we find that the toilet is actually outside the house. And in our own homes, the person may be kept in a particular room, but access to the toilet might be through the corridor, or outside their immediate bedroom. They don't have access to it en suite from their room. And how does that impact their care? And do they need then somebody to so recently I was talking to somebody who has a brother who's 6 feet tall, 2 inches, and he has a progressive neurological condition, and the family is there, but every time he has to go to the toilet, it takes 2 people to hold him up and take him there, and to be with him. And because they live in an apartment in Bombay, and it's not attached to the main bedroom, they have to actually navigate a couple of corners to get to that toilet. So that also impacts the overall quality of life of the person. Okay. Waste disposal. So I'm just going to skip through this. A lot of this is very, it's like I said, it's coming from the community health perspective. And I'm skipping through these slides. Okay. Now we come to something that is very important, which I think was covered in one of the first sections of introduction to palliative care and stuff. This is where we set our assumptions aside. We might find, after assessing all that, where they live, what they do, who's at home, who cares about them, all of that information. But really it's to come down to what are the ideas, concerns, and expectations of the patient, and separately, what are the ideas, concerns, and expectations of the family. I might go in thinking, array, now this guy needs physiotherapy. His major concerns must be, how can he get to a physiotherapy center? That may not be the main concern. Their main concern might be, my mother has a backache because she's constantly trying to lift me up and help me sit back down. Can you please take care of my mother's back pain? That might be the first concern. What are the ideas about their illness, about what has happened to them, about all of that. Expectation. Why are you there? Not everybody is going to see you as a helper, right? Now that you've come to visit them, you want to visit them because you want to offer them the best palliative care. But now that they've let you into their home, you looked around, they might actually expect financial aid from you. So be mindful of the fact that what the patient expects. Now, you have to then make it very clear why you're there, right from the start. Don't assume that they know what palliative care is, or what the team is, or what your organization does. Yeah. So, so similarly for families also, please be very mindful of their ideas, concerns, and expectations. The Western universities, medical universities across the world now talk about narrative medicine. Narrative medicine. Narrative medicine is a medicine that is designed to elicit stories and narratives from the patient and understand, where they are and who they are and what they want. And it's a narrative style. And from there we decide, okay, what is it that they really need? It's the same thing. Okay. I'm going to skip these. Now, needs. What is the felt need? The patient might say, right now, this is what I need. what the patient also needs as assessed by you guys, yeah, the assessor and the clinicians. And this is where addressing the concerns, expectations of the patient become the crux of it. So this is where the Venn diagram comes in, where what they think, what they feel they need, what you think they need, and where the intersectionality is, that is the priority. Okay, so I'm going to stop with this for the time being, and we're just going to throw the floor open for some discussions. And I want you to really think about, if you can share with me some of the cases that you've experienced, and if you were able to intuitively apply some of the stuff that I just talked about, or do you feel that, you know, some of this stuff gets missed on a regular basis? And if you find that any of this can actually be used in your practice, I'll be happy to hear from you. And if you can have cameras off, on, that'll also be good. Yes, Nupur, please.
I'd like to share my experience.
Please.
All these are like real life situations, but at the same time, I was working in Mumbai slums under PHC. I was heading a PHC. So the difficult, sometimes now we have seen, you know, the people from different states misusing the local, you know, availability of government funds for their own benefit. Now, for example, a couple from UP would keep on producing children, believing that they're getting all the perks from the local government in Mumbai, like free education and all. And sometimes there are these for example, there was a couple from Tamil Nadu who was expecting to get, since they had a first girl child, and in their local village, they were given 50,000 rupees for a girl child, first child, if it's a girl. So they were also expecting that Mumbai municipality should also give them 50,000 for the first girl child. So that is how this has been misused. So how do we really help these people? Because they look like poor, but they are also misusing the same thing, that they are very clever, that they will use their caste certificate everywhere to get money from multiple NGOs. They get a lot of money. Sometimes they have a lot of money. They have a car. They're living in very lavishly in slums. They have everything, but they will still want money from multiple NGOs. So in that scenario, how to go about? Because they're very nasty. I find sometimes they're very nasty. Not only that, even when the government is going for building their slums into SRA, they will try to divide their houses into 2 to 3 parts, and then try to get 3 homes and all that, and then they will sell it off, and then they'll live a lavish life. That is also happening, you know.
There is something called rational compassion, and that involves not being taken for a ride. So I'm not saying that, you know, there are always people who will misuse the system to further their gains, and to believe that, you know, if we are in a helping profession, then help also has to be completely, you know, uniform and equal. Help that we offer is also equitable, right? If somebody has the means to get access to the kinds of subsidies and things that they need from elsewhere, then that's a boundary that we need to be able to draw. Now, it's unfortunate that that requires us to, the danger there is that we start viewing with suspicion, and our default setting becomes, you know, we're looking for, okay, where could this person possibly be, you know, taking me along for a ride? I'm not that idealistic enough to believe anymore, at least, that you know, everything is to be taken at face value, which is why I would say this kind of thing becomes to sharpen our own discernment and to sharpen our own observation skills is not just something that enables us to help other people better, but it also enables us to safeguard ourselves as well, in the sense of knowing where our boundaries are. And saying no in these settings is not an easy thing, because, what if you're wrong about it, right? But I know, Nupur, that you're probably not alone here. And I'm sure there are other people in this group who've had similar experiences. So if there's somebody here who also wants to respond to Nupur, then please, by all means, go ahead. I don't have an answer to your question, Nupur, in case I haven't made that clear. It is really about using our discernment. And not to say that we've not had issues like that as well. We've also had issues like that. And we've also had issues where I would say, been almost held hostage to the fact that if you don't do this for me, I will actually go on social media and tell everybody that you guys actually don't do what you say you do. We've been on the receiving end of that as well. So does that make us stop doing what we do? No, because the vast majority still need what we can give them. So it's a very tricky balance, I would say. We burn our fingers a lot, and then we have to figure our way around it. So would anyone else like to respond to the point that Nupur raised? I think it's an important point, because it calls into question not just ethics and morality, but also just practical ability to support people and without burning out as an organization. Nobody?
Yes, ma'am, I would like to say something. Like she said, that's very true. But in any case, people who come from this class of the society, at least are bold enough to say that they need help, and probably they get help from many sources. But the middle class, the ones on a little higher side, but still have economic problems and a lot of struggles in life, and but can't avail to these help, or get access to these helps from anywhere, not from the NGOs, not from the community, not from the government as such. So they are the ones, I think, suffer more in such cases, and I think we should also approach to them. And even if we feel that they don't need so much, but still they need help, it's like the living conditions, and they though they might be having a certain amount of income, but that is not sufficient for them to in during crisis, when they are having a disease, or a person affected with some certain disease like a cancer or something like that. So I think for them, I think help is even more needed. That's what I feel.
Thank you. Have I shared that quote here with you, where Dr. Roop Gursahani, what he says? Dr. Roop Gursahani is a consulting neurologist in Hinduja Hospital, and he is one of the founders of End of Life Care in India Task Force. Now, mind you, a very senior neurologist in the country. He was actually the one brought in by the Supreme Court to assess Aruna Shanbag. So those of you who know that case. And there is this quote by Roop Gursahani that I've used in a lot of forums, where he says, modern day, private hospitals are like fortresses. The poor can't get in and the rich can't get out. And so we talk about marginalized communities in terms of access, right? A huge paradox exists in India, where one of the most marginalized communities when it comes to accessing palliative care and pain relief are the affluent, because they end up in high-tech hospitals, private hospitals, that don't believe or don't have training in palliative care. Like I said, palliative care is not a profiteering discipline, and therefore, these people do not have access to palliative care and pain relief. So to Amatola's point, there are different levels of disparity and access issues, and certainly it's not confined to the very, very poor. Right now, if I were to just check around this room right now, I'm sure there's a percentage of you that know exactly what I'm talking about when I say, the poor can't get in and the rich can't get out. And I'm sure there are many people here who have witnessed that. You try taking somebody off, getting somebody discharged from a high-tech hospital so you can just take care of them at home because futile treatments there are not working. Just see the kind of resistance you will get. The amount of guilt tripping you'll also experience, right? And I'm sure there are beautiful hospitals and doctors who also ensure that that doesn't happen. But unfortunately, the majority experience still remains this. So what we're seeing here from what Nupur has described, yes, there are people who will try to take advantage of a system that is geared to help them and therefore cripple the system. And then on the other hand, we have people who can afford all of this stuff, but they don't actually get what they need. So the more we get into this field, it's like a wormhole. I'm sorry, for me, my journey into palliative care has been, it's been this, where you after a while, you can't look away from this stuff. And I remember going into a hospital like many years into my palliative care practice and having this experience with a particular healthcare team. And I remember calling Dr. Raj Gopal and saying, like, I don't know what's going on now. I'm only looking at it through this lens. And he said, unfortunately, you've taken a bite of the forbidden fruit and you're never going to unsee, you're never going to unsee all this. So good luck with all your misery for the rest of your life in the rest of your healthcare career. So I'm sorry to be offering you that fruit also with every session, but I mean, that's what it is, right? Like we just have to be mindful that disparities exist on all levels. So it's very nice for us to sit on a nice, Friday afternoon we have access to technology that allows us to be part of this classroom and have all these conversations about equity and justice and all of those things. But I think these are also important conversations, and I'm really glad that some of you have highlighted some of these issues. It's not a rosy picture at all. And I don't think these classes are places where we can actually find quick solutions. But the fact that we're here and sharing these experiences, I think is the gift. Anybody else would like to share any experiences and then perhaps reflect on some of these points, and then we can start winding down. So I'd like to make a point of one thing. The comments or the opinions raised about the healthcare system. I know we're focusing on the negative stuff, right? But I would really like to reinstate the fact that there is tremendous work also going on out there. I'm not here to challenge or raise this as an issue, in the sense that I think if we're truly going to move forward, it cannot be a confrontational exercise. It has to be a collaborative one. And we're all going to need access to the healthcare systems. We're all going to need access to doctors. Some of us are lucky to have extremely good, caring, ethical doctors. Some people not so much. But at some point in our lives, we're either going to be carers or we're going to need care. And at that point, we're going to need the healthcare system. So I hope that, some of these points that we've discussed today help you in your day-to-day practice. I hope that, the assessment parameters that I've shared with you will perhaps, enrich your work. I'm sure most of you are already doing this kind of thing, but to just really look with fresh eyes at the people that we serve. Because there's a lot of stuff out there which is theoretical. A lot of it is borrowed from the West. But when you really apply it to the Indian setting, you find that, you have to do this exercise in what we call ground truthing. You have to walk into those spaces where people who you serve live. And that's when you really start informing your practice on what is needed. So I'm going to stop with that, Sinia. I think we have a few minutes left. If somebody wants to share something, that's fine. Otherwise, we can close the session for today.
Okay, ma'am. Nobody has anything to tell? No responses. I think
It's one of the things, right? It's always either everyone's agreed with everything or like.
I would like to share something, ma'am.
Sorry?
I would like to share something.
Go ahead, please.
I don't know if it's actually to the context from today's point of view. My brother is an oncologist and he believes in service and he's doing quite a lot about it. But the ratio of a doctor to the patient is like, there's a lot of imbalance in the ratio. So the kind of service he actually wants to give is not possible. So I mean, he would just say that do this, do that, but to go into the depth of whether that patient can do that is not his concern, cannot be his concern. Though he tries, but he cannot look into that. And I think there's where palliative care comes, where the patient, the doctor and the patient, there is a gap. Even the patient doesn't feel comfortable to convey such things because the patient knows that the doctor is very busy and will not bother about these small things. So, and there's a gap. Someone like just cleaning the wounds cannot be done at home. And that itself, like in a cancer patient where he is dealing with oral cancer, ma'am. So people come with so much of infection where only just if it could be kept clean, half the progression of the disease could not be such like it is. So so there is where palliative care needs to go into, and the ratio also needs to be adjusted where we have to have more doctors to treat.
Absolutely, I couldn't agree with you more. And when you said small things, actually, those are the big things. I remember this exact question being posed to Dr. Raj in a we had a screening of the film Hippocratic in a very upscale place in Bangalore, and it was a room full of very accomplished senior doctors. And then I remember at the end of the screening, we had an interactive session and all of that. And then one doctor put their hand up and said, "See, Dr. Rajgopal, this is wonderful. We loved your movie. We loved everything. But you're doing this out of a sense of purpose, and you've retired from regular medical practice, and this is what you're doing. But the rest of us, we don't have the time to do this." And so time to do what? Like, okay, so I'm not by no means, Amatullah, this is a comment on your brother, but this it was a simple thing of how many of us know our patients' names, huh? Or the caregiver's name. It's tremendous how in taking their name we afford them dignity. You may not be able to fix their problems at home, the fact that there's nobody to do a wound cleaning or whatever. So I remember the answer Dr. Raj gave this lady was, "Madam, when you have a patient who has XYZ thing and is choking, can't breathe, what would you do?" And she said, "Give him a tracheostomy." So he said, "How much time will that take?" 20 minutes. Okay. And how long will it take for you to ask a patient if how they are and how they're coping or whatever? And she said, "A few seconds, but this is a life-saving procedure." And he said, but having that conversation could be the life-saving procedure that you're having with that family as well. For someone to just ask, "How are you?" could actually be the first kindness that that person has experienced at the hands of the healthcare system. And at Pallium, I've now been in Pallium for about 9 years. I cannot tell you how many times families have come to us and they've been knocked about the system for 4, 5, 6 years. And when we sit down and do a quick assessment and say, "Yes, so your name's," and look at the caregiver and say, "And what's your name?" They're shocked because all of that time they've been called bystanders. And now suddenly they're being seen as a human being. So no, we cannot mobilize the kind of support that I've talked about today, but I'm talking specifically from a palliative care perspective. I believe that the problem is that palliative care is seen as a specialty. This is the stuff that a palliative care team does. The palliative care team has a multidisciplinary team. So the social worker can go out into the field and all that. You don't have to have a palliative care team, but you can have a palliative care approach to things. And, if we can't fix a practical problem, at the very least, we should be mindful that we can fix, or we can at least make sure that their dignity is not also broken down in the process. I know this sounds esoteric and kind of philosophical, but if a person is met with kindness in the healthcare system, it actually goes a very, very, very long way. What you talked about, the communication barrier, most patients will not ask a doctor a certain question because they feel that he's too busy, or they feel that they can't. But just in being, kind to somebody and just saying that, it actually opens up several doors of communication. Why is it that, and I don't know if some of you might have encountered Dr. Biju Raghavan, who talks about communication, medical communication. He says sometimes the posture that doctors take in itself is you're not welcome to have a conversation with me, right? So it doesn't have to be, and I completely understand we're completely short-staffed. I'll end with one thing. There's Dr. Aju Matthew, who is a very senior medical oncologist. He works out of Cochin. He was from Trivandrum, went and did his oncology in the US, etc. He's come back, and I facilitate a lot of conversations with Aju between cancer patients and him. And there's something beautiful. He's not going to like that I've said this on a public forum, but he does video Zoom calls with people who have the privilege of doing a Zoom consult. His consultation fee is about 500 rupees, but he doesn't take it. He gives you the bank account details of one of the patients he has who is impoverished, and your fees goes there. The second thing this man does is something that he calls a wallet biopsy. He say, okay, you have this kind of cancer. This is what's happening. Now, these are the treatments available. This is top of the range. It's just gone through so many clinical trials. It's cutting edge. This is what I recommend because I've worked with this for so long. At the end of it all, the price. What will it cost you? You need 8 rounds of this. You have money to do the first 2. What happens after that? Are you going to have to sell something? And so it's not to say, I want to make this very clear. It's not to say that therefore you should get cheaper care. No, but go into it knowing what you're going into. If you want to do this chemotherapy of 8 rounds, know what it's going to cost you at the end of it. And know that this is what the results are showing and whatever. So the options are given. So halfway through that chemotherapy, the family suddenly is not having to sell their car and then their house and then something else. They've made a decision knowing what it's going to cost, and they have the time to prepare for that. And I can tell you, he's a very, very busy oncologist as well. So like I said, there are some absolutely beautiful, and I love that your brother has that sense of service. And sometimes it is the system that makes it very difficult to have the time to, even have these conversations. It's a very stress-inducing system. I really hope your brother finds his place and, that heart of service is given a place to grow. So thank you also for sharing your story.
Thank you, ma'am. He's the one who put me into this course, and he himself is also enrolled into the advanced one. He's Dr. Burhanuddin. He's an oncologist from Tata Memorial, and he's working in the 3-tier city of Muzaffarpur, setting up cancer specialists there.
Fantastic. What a great family. So great to see that you're in 2 separate courses, and then it's just gonna add to this. Thank you. We're at the end of our time. See you all soon whenever the next session is, and I hope you have a good weekend and stay safe. Thank you very much.
Thank you, Smriti ma'am. Indeed, it was such a wonderful session. I think it was a very interactive session. I hadn't been through this hacks even before. Thank you. And all of you, thank you, because you made this session wonderful. You all participated well, and we are expecting to have such wonderful classes again with both from both ends. And thank you once again. And please, kindly, please give your feedback. The link is already provided in the chat box. Please go through it. And your feedbacks means a lot to us. And thank you once again. I am signing off from this session. Thank you.